Hello, we're glad you've joined us for this live webinar, Procalcitonin and its importance in the emergency department. I'm Judy O'Rourke of LabRoots, and I'll be moderating this session. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. It's brought to you by bioMérieux, a world leader in the field of in vitro diagnostics for over 55 years. bioMérieux is present in 43 countries and serves more than 160 countries with the support of a large network of distributors. bioMérieux provides diagnostic solutions, systems, reagents, software, and services which determine the source of disease and contamination to improve patient health and ensure consumer safety. Its products are mainly used for diagnosing infectious diseases and some critical illnesses. The company's diagnostic solutions are also used for detecting microorganisms in agri-food, pharmaceutical, and cosmetic products. To learn more, visit www.bioMérieux.com. Let's get started. You can pose questions to the speaker during the presentation while they're fresh in your mind. To do so, simply type them into the drop-down box located on the far left of your screen labeled Ask a Question and click on the Send button. Questions will be answered after the presentation. To enlarge the slide window, click on the arrows at the top right-hand corner of the presentation window. If you experience technical problems seeing or hearing the presentation, just click on the Support tab found at the top right of the presentation window, or report your problem by typing it into the Answer Question box located on the far left of your screen. This is an educational webinar and thus offers free continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process of obtaining your credits. I now present today's speaker, Dr. Daniel J. Feinstein, FACP, an Associate Clinical Professor of Medicine at the University of North Carolina School of Medicine. Dr. Feinstein trained in internal medicine in Baltimore at St Agnes Hospital and then at Rush Medical Center for critical care medicine. He is an adult intensivist and has performed research in septic shock and antibiotic administration. Dr. Feinstein has been a pioneer in antibiotic stewardship and sepsis care. Dr. Feinstein will now begin his presentation.
Thank you for the introduction. It's great to be here. I'm excited to discuss the topic of procalcitonin and its use specifically in the emergency department. I'm an intensivist full-time, and I think I've had a unique opportunity to be in the emergency room quite a bit and then continue to take care of these patients during admission to the intensive care unit and the step down on the floors. So it allows me to have a reasonable understanding in terms of the sepsis transitions and sepsis care. I continue to do research specifically around sepsis and procalcitonin and lactic acid, and continue to be a consultant with bioMérieux. For today's talk, we are going to talk specifically on procalcitonin use in the emergency department. We're going to go over an introduction, the pharmacokinetics of PCT. We're going to look at PCT use and using it as a tool in differential diagnosis in terms of distinguishing the difference between viral and bacterial infections. We'll look at the positive predictive value of using PCT for early identification in sepsis patients. We'll look at the emergency room's need of using PCT for antibiotic stewardship. And then we'll look at triaging in the ER and the value of PCT on triaging and the outcomes and using that as a predictive model on some decision making. And then lastly, we'll close looking at lower respiratory tract infections in the emergency room and those patients who get admitted or even are discharged from the ER. So everyone's very familiar with sepsis. If you're not excited about sepsis now, then I don't think you'll ever be excited about sepsis because it's just a huge focus throughout our country. Right about now, there's probably about 1.15 million incidents of sepsis predicting in the year in 2020. And so it's a very common cause of death in the United States, unfortunately. And despite all the awareness and guidelines and and the surviving sepsis guidelines and the bundles, we still have some work to be done in sepsis care. In particular, the antibiotic stewardship piece and the potential negative aspects of providing aggressive antibiotics, fluids, et cetera, to patients who don't even meet criteria for sepsis. I know a large majority of you are familiar with Surviving Sepsis campaign and then the subsequent CMS bundle, which in general mirrors the Surviving Sepsis campaign. The 3-hour bundle, very important, and the 6-hour bundle follow-up and addressing hypotension. We're all charged to be very aggressive, which we should be in cases of sepsis. And when I look at PCT and where this potentially fits in, it's really on two ends. The first end being early identification. If you can't identify these patients, and sometimes we don't, or we have delays to identification, then we can't initiate the Surviving Sepsis campaign bundle and try to improve outcomes. On the flip side are the issues in terms of overutilization and providing aggressive sepsis care in those cases that in the end did not turn out to be sepsis, and using PCT potentially for its negative predictive value of a discontinuation of antibiotics that are not necessary further. We use biomarkers on a daily basis, troponins and BNPs and cortisol levels and PCT, lactic acid levels. All of these are biomarkers, and they aid in risk stratification. They can help us with prognostication. They can identify the presence or absence of a disease such as sepsis. We can monitor a response to patients to our intervention, such as antibiotics. We can use PCT as a biomarker to serve as a surrogate endpoint for discontinuation of antibiotics. So there's multiple roles for PCT, and we're going to cover a large majority of those specifically in the emergency room. So let's start off by having some very important knowledge in terms of procalcitonin's kinetics, how is it produced, and then talk briefly about some of the false elevations of PCT in inflammatory conditions. So procalcitonin is produced primarily in our thyroid at baseline, some in our lungs, and it starts out as procalcitonin, 140 plus amino acid structure, and it rises in the setting of a bacterial infection and SIRS, which is important. Sometimes I get questions in terms of basic urinary tract infections for patients, and unless they have SIRS, PCT is not going to mount a significant response. PCT fortunately rises very quickly within 3 to 6 hours. It has a half-life of about 22 hours and can aid in early identification of patients with sepsis and bacterial infections with SIRS. In the setting of bacterial infection and SIRS, it starts getting pumped out at 100,000 times the traditional baseline levels of PCT. And at that point, PCT is being produced by thyroid and lungs, but organs in our abdomen, organs in our in our brain, multiple other organs start producing PCT. In healthy individuals at baseline, PCT concentrations are less than 0.05 nanograms per milliliter. But in the setting, again, of a bacterial infection and SIRS, you see this rapid rise of PCT. And what's very important to note is that as a patient's acuity gets worse, PCT will continue to rise within that host until infection is controlled and treated appropriately. PCT can be elevated in some rare neuroendocrine tumors. I've never seen that. Maybe I wasn't looking hard enough. But more commonly is PCT elevation in other inflammatory conditions such as post-CABG or valve replacement, trauma patients, burns, bad pancreatitis, bad ARDS. And those levels, you can use PCT, but just recognize that in those illnesses that are just inflammation, PCT gets to this kind of 2, 3, 4, 5 range and kind of stays flat. Very similarly is patients with end-stage renal disease. Patients with end-stage renal disease can have low-level PCT elevations at baseline related to their lack of clearance. But in all these groups I'm just talking to you about, inflammatory conditions, if you see PCT that's at this 2, 3, 4, 5, and then it jumps up and rises to 10, 15, et cetera, maybe in a VAP patient, that certainly can be useful and indicative of a new infectious process. So PCT has been FDA cleared since 2007. At that time, it was to aid in risk assessment for sepsis and septic shock, specifically on the first day of ICU admission in the emergency room. And since then, in 2016, the FDA looked at a good bit of meta-analysis and good data that then cleared procalcitonin's use for what I've been using it for since 2010, which is to aid in antibiotic discontinuation and antibiotic stewardship, the negative predictive value. In the same cohort of this Cochrane analysis the FDA looked at, they also approved procalcitonin for lower respiratory tract infection use, such as community-acquired pneumonia, of which 80% is viral, acute exacerbations of COPD, and bronchitis, which we're going to discuss. So let's talk about the use of PCT in the ER for trying to differentiate viral versus bacterial infections and then other non-infectious causes of illness. Medicine is hard, and these patients just present very similarly. Patients with pneumonia, patients with viral pneumonitis, patients with autoimmune pneumonitis, other non-infectious pneumonias, even heart failure. They all present very similarly, and so you need as much help as you can get to try to help differentiate the cause of their disease. Fortunately, it looks like with bacterial infection, lipopolysaccharide produces specific cytokines, and then you have this kind of robust, again, production of pre-procalcitonin, which eventually gets cleaved to PCT. In viral infections, however, interferon gamma is produced, which essentially blocks the production of procalcitonin, and therefore you can use this to try and differentiate between monoviral infections and then patients who have bacterial illness on top. PCT, again, rises rapidly after this bacterial insult, and it offers pretty good specificity for differentiating a bacterial infection versus just true inflammation alone. The studies are pretty good on this, some as large as about 300 patients, looking at trying to differentiate viral by itself versus viral plus superinfection or bacterial infection on its own. This is a study that tries to look at a specific value or a cutoff to try to differentiate between sepsis and non-infectious SIRS, or just inflammation. And this is a meta-analysis, 30 studies, including about over 3,000 patients, looking at the sensitivity and specificity, more of a lab sensitivity and specificity. But it seemed to find a sweet spot or a value of about 2 or 2.2, where above that you really should be, concerned that a bacterial infection is present. This is again, just trying to reiterate the levels very significantly elevated in patients who are having bacterial illness versus a viral illness where interferon gamma is inhibiting the release of PCT. And somewhat similarly is fungal infection. Fungal infection as well, you can have some low-level PCT, but overall stays statistically significantly lower than those with bacterial infection. This is a similar idea, looking at PCT levels being found much higher in this study in intensive care medicine 2011 on those patients who had bacterial co-infections who also had a viral illness versus those patients who had viral illness alone. Let's talk about the positive predictive value in the emergency room, looking at how can we identify these patients with sepsis where maybe before our clinical know-how alone could not identify them. And then some of these cases of which anyone online who has used PCT you're going to get surprised. You're going to see some levels that are elevated significantly and really is very helpful in terms of initiating sepsis care. Like most and all blood tests, no one should be using procalcitonin by itself. It's all about using your clinical judgment, your clinical know-how, and combining it. You can see with PCT, you see the area under the curve getting larger and having improved sensitivity and specificity for sepsis patients. This is, I think, a very important slide that looks at PCT's receiver-operator curve with sensitivity and specificity, and it looks pretty good. You know, in the ICU and in the emergency room, we use a lot of tests, and you know, none of them are perfect, and neither is procalcitonin. But overall, when you compare it to everything else we have for sepsis care, it does a pretty good job. I want to draw your attention to the green line with lactic acid. We need lactic acid. We should continue to use it for perfusion status. It is not something that any of us use to discontinue antibiotics. And we should always recognize how nonspecific lactic acid is. It rises with glucophage and cardiogenic shock, and it rises with hypovolemic shock, and it's obviously very non-specific. Actually, right now, I'm involved in a study of 1,000 patients trying to use PCT and lactic acid and see if they're synergistic in the evaluation of our patients in the emergency room. This is data from my group with Nan Kumar, where in 2006 was published in Critical Care Medicine. We looked at retrospective data looking at septic shock patients and discovered, of course, where for every hour and delay after patients fail fluid resuscitation, there was a 7.6% rise in mortality. So we do our very best as clinicians. Some of these patients get delayed to diagnosis. I've had numerous cases where, again, I was surprised by a positive procalcitonin of 30 or 40 or 50. Never thought I'd see it, but it really was the only thing that really tipped me off to considering empiric antibiotic use. Again, medicine is very difficult, and we got to kind of use every tool we have in the toolbox to try to take care of patients. In our study, we found that when patients received appropriate antibiotics, well, in this case within 30 minutes, and that was 82% of the patients, their survival was 77% within 1 hour of antibiotic administration. You can see the survival fraction of the longer you go with delaying antibiotics, really mortality unfortunately rises just drastically. This phenomenon of being able to identify patients as quickly as possible and being able to treat them and trying to reduce mortality, the phenomenon that we found with a 7.6% mortality increase when we delayed the diagnosis and treatment was found in all cultures. It didn't matter if you were bacteremic or not. It didn't matter where you came from in terms of community or nosocomial. It didn't matter if you were culture positive or culture negative. It stood. It also didn't matter in terms of the source, and it also didn't matter in terms of the organism. So, again, it just becomes crucial to identify these patients as fast as possible and start antibiotics. In terms of lactic acid, again, we should not be substituting PCT for lactic acid. We should be continuing to use lactic acid for perfusion status. This is a study of emergency room patients, 840 adults, and it looked at patients' lactic acid levels and looking at mortality in severe sepsis patients. And regardless of if you were in shock or not, if your lactic acid was elevated, regardless of if your blood pressure was low or not, it was a poor predictor, and you were going to do worse. So if you think about that, the times of patients, quote-unquote, looking good with a lactic acid of 8.5 with diagnosis of sepsis are kind of over of not being aggressive for them. So being able to identify them and correlate that with lactic acid and patient presentation with the use of PCT, it can be very, very helpful. When patients clear their lactic acid, that's what we want. Patients do better. But again, it all goes back to using everything we have in our toolbox of having a rapid identification process in the emergency room, in the triage, of identifying these patients rapidly. And if you have an elevated PCT, that potentially can help you get to treatment faster. Now, let's talk about antibiotic stewardship. And we'll talk about getting a baseline PCT in the emergency room, which of course goes with a negative predictive value. When I first set up a sepsis program in my prior health system, the emergency room doctors fortunately understood this, that we had to, and if I didn't get a baseline from them, it made things a little bit more difficult in interpretation of using PCT for its negative predictive value over time. We all know that inappropriate antibiotics is a huge problem in our country, and it creates major safety issues. It's estimated at 2 million illnesses a year in the United States and 23,000 deaths, which is probably overwhelmingly C. diff, comes from inappropriate antibiotic utilization. I really like this next slide because I think it's an important thing to understand. We get cultures in the ER, and we treat, and that's what we should be doing. We should always rely on our clinical know-how with aggressive treatments for what we think is sepsis in the emergency room, and then kind of get our PCT and let the dust settle a little bit later. We have to recognize that we get ourselves in a gray area for 2 or 3 days where cultures are pending. We're relying, of course, on our clinical know-how. 50% of patients are culture negative who come in with sepsis and septic shock. 15 to about 20, in some studies 30% of the time, we don't know the source. So PCT and our clinical know-how is kind of really what we can have during this time period of trying to determine patients' needs for antibiotics and even escalation of care. This is a study which is an outpatient study, which I think is actually published on the CDC website, and it basically was infectious disease doctors reviewing charts of patients who came to a clinic with a respiratory illness, and they determined if the antibiotics were basically necessary or not. And unfortunately, with this almost 70 million patients, half the patients received antibiotics inappropriately. And I think that this extrapolates quite nicely to the inpatient world, my world, where these patients commonly still, we get antibiotics and they just simply did not require antibiotics. So the FDA had looked, as I mentioned, in 2016 at large meta-analysis, 11 randomized controlled trials, Cochrane analysis, over 4,000 patients, looking at the use of PCT versus traditional, guidelines and standards. And for sepsis patients, when they drilled down, it showed a significantly reduction in duration and exposure to antibiotics in the patients who were utilized with Procalcitonin for their management. And look at the bottom here at the table. I frequently get a question, Dr. Feinstein, can I just use negative PCT values? And when we have 3 negative PCT values, then we can discontinue antibiotics. The answer is sure. Yeah, you can. But look at the very bottom line in the patients who had elevated PCTs, and the clinicians look for an 80% reduction from a higher value. You can still see there was a statistically significant reduction in duration exposure to antibiotics in the patients who were utilized with PCTs that were elevated, and following them over time to see a reduction. From here was a 23% reduction overall with antibiotic exposure for the patients who had PCT utilized versus controls without. There was no mortality, adverse mortality signal associated with the use of PCT group for sepsis care. And so here's kind of what it looks like. You have your patient who is in the emergency room, and you're evaluating them for either, in this case, sepsis or lower respiratory tract infection, which we'll tackle near the end of the talk. You're going to get a baseline Procalcitonin. We're talking about a negative predictive value now, something the ER clinicians may not necessarily be able to utilize immediately. If it's totally negative, you're going to go with your clinical know-how. And you're going to follow the patient's progress or lack of over time with daily procalcitonin levels up to 96 hours. If it's flat or rising despite what you're doing, then you are concerned that you're missing a source or you're missing the organism. And that's a patient, again, who's kind of flat with their clinical progress or lack of. And then you have the patient going downward, which is negative or low PCT levels, and a patient whose clinical status is going in the right direction. A lot of opportunity then for discontinuation of antibiotics. So we're talking about two patient groups, and I want to distinguish between them. We have our sepsis patients, where you are evaluating them in the emergency room. We need the baseline procalcitonin for its negative predictive value from our emergency room colleagues, and then we're going to monitor them over time, looking for less than 0.5s or an 80% reduction, which gives us the potential of discontinuation of antibiotics with a good clinical status. And then you have the lower respiratory tract infection patients who have different values, which we're going to cover on a little better, clearer slide with the actual values, but they come in and they are not sick compared to the sepsis patients. I think that's a really important thing to recognize here. The patients who are presenting to the emergency room with either concerns of COPD, exacerbation, bronchitis, or pneumonia, these patients do not have sepsis. They're less acute, and so we have time to monitor them with PCT levels and their clinical status with or without antibiotics, and use PCT to discontinue or not start them. But they're not as sick. This is just a slide that looks at an example of a protocol for the use of PCT. My strong bias here, and I've seen it over and over again, is that procalcitonin should be standardized on a protocol order set. When you allow kind of one-off, knockoff orders through your EMR, it really doesn't go well. When you have you get kind of people who are not being compliant with the value. You're skipping the trend. Things that, to be quite frank, could be harmful. When you standardize procalcitonin on an order set, you're allowed to put then inclusion criteria. You can see here exclusion criteria, and then even recommendations, of course, on discontinuation or continuation or escalation of care based on patient status and the values. This is a really interesting area in the study that we're doing right now with 1,000 patients looking at PCT and lactic acid levels and outcome. One of the things we're also looking at is ER triage, and those patients who don't come to the intensive care unit, who then crash within 40 hours and then come to the intensive care unit. And so there's a lot of potential here with the use of PCT in directing triage from the emergency room, or directing an increase in the aggressiveness of care, and I'm going to go over that. And a lot has to do with, of course, elevated PCT levels and the outcomes associated with that. So we're going to go over a couple studies, and I think this is pretty important, specifically to the audience that we have today. So I told you before that PCT levels within each host will correlate with severity. So the sicker you are within each host, the higher the procalcitonin level. The one other thing to remember, which is quite important, is that you can see procalcitonin variability from one patient to the next. So you can have one patient who's got horrible pneumonia and sepsis, and their PCT is 9, and you can have another patient with the same diagnosis, same chest X-ray and a presentation, their PCT is 49. But within each host, it will rise depending on their acuity as they get sicker. This is a study from the emergency department that was an observational prospective trial looking at 120 patients who are adults, trauma people. And you can see they simply just measured PCT levels, and the higher the PCT levels are found in the patients with septic shock, in this case, versus sepsis or SIRS or even non-infectious causes. So that kind of, again, would alert you potentially if you have a very elevated PCT. You may kind of question what are you going to do with that person? Where are you going to put them? And do you need further imaging, for example? And you can see the p-value here at 0.001. This is a small study, granted, There are many other out there that looked at procalcitonin levels in ICU admission patients with community-acquired pneumonia. And you can see the patients who didn't go to the ICU had much lower procalcitonin levels. The patients who went to the ICU, no surprise, had higher procalcitonin levels. It's the last column there of the delayed ICU patient, the one who didn't go to the ICU, who basically declined and ended up within 48 hours crashing and coming to the intensive care unit. Those patients have elevated PCT levels compared to those who didn't go to the ICU and stayed out of the ICU. So I think that's a little bit telling. Again, small numbers overall, and there's some unequal patient groups here, but we can show you plenty of other studies that continue to show that this is a marker for someone who's not going to do well and maybe needs a higher level of care. Another similar study, but a teensy bit different, I'll explain that. This is a study from Philip Schutz's group in Europe and the United States, so in Switzerland, France, and the United States. These are 7,000 basically patients prospectively studied to try to see if admission emergency room procalcitonin levels could predict mortality across different medical presentations, and including sepsis. And it looked at mortality and their specific medical diagnosis. And what was found here, again, which was that PCT was a very strong predictor of an independent outcome for 30-day mortality across all different types of medical diagnosis. Their ICU admission risk with a p-value of 0.001 was higher when PCT was elevated, their mortality, as I stated, and their readmission rate as well. Now, and that's all for infectious patients. Looking at other non-infectious presentations such as metabolic disorders and cardiovascular disease, and even with young patients, it looks like that PCT also was an independent predictor of doing poorly. And also in this study, it found that PCT, when added to QSOFA, improved receiver-operated curves and area under the curve for sensitivity and specificity. So I think that, so I've been convinced for a long time that when PCT is elevated, you ain't going to do as well. And so I just beg the question that when you have specifically very elevated PCT levels in sepsis, and even in this example, maybe other medical conditions, do you do something different there? I think time will give us more information with more studies, but that's really what this is, what I'm asking. This is data from the Moses trial that looked at PCT levels over time and looking at their survival. And it looks like, again, the higher your PCT value, you do poorly. But those patients where your procalcitonin stays flat or rises and doesn't drop by 80% or more over 96 hours, those patients do poorly. And another really, I think, a good study by Jensen in Critical Care Medicine. They just basically, very simple, they ordered PCT levels on day one in the ER and subsequent days and looked at patients' outcomes, and it showed that the higher the maximal procalcitonin and those patients whose PCTs continue to rise, the worse the mortality. So I've had cases in the emergency room. I've seen PCTs of close to 300 and 270 range. I think you need to ask yourself, do you do something different in those cases? Is that someone who you get to the operating room maybe a little faster than you thought you were? Is that somebody who maybe needs some additional imaging? You thought it was cellulitis and it could be, abscess or necrotizing infection. Does that person get additional imaging? And where do you put that person? I think we need more data on this, but where do you put that person? Do you just put them on the floor? Or do you put them in a step down for closer observation? Do they go to the ICU? Those are the questions we should be asking, and I think there's certainly a role for PCT in helping you make that difficult decision. So let's now talk about lower respiratory tract infections in the emergency room. We're talking about, again, COPD, bronchitis, community-acquired pneumonia, and the use of PCT. These patients present very difficult sometimes. They have some mucus, they may or may not have fevers, may or may not have shortness of breath, and they're tough I think they're tough to handle. And overwhelmingly, everyone on this call knows that person with maybe bronchitis, it probably is viral. A lot of those patients get antibiotics, and they simply didn't need those antibiotics. This is the algorithm that the FDA looked at and looking for lower respiratory tract infections. And the cutoff values are a little bit lower than that with concerns of sepsis. And again, these patients are not as sick as sepsis patients. You have time to observe them. You have time to observe them off antibiotics if their clinical status will allow. And the cutoff values here was if it was less than, with 0.25 or less, it was discouraged to provide antibiotics, to start antibiotics. If it was 0.26 or greater, it was encouraged to provide antibiotics in those patient groups. So you have an option here. You can observe them and admit them, and not provide antibiotics if their PCT was less than 0.25, and you can even repeat the PCT the next day. Or if you decided to provide antibiotics, you can repeat the procalcitonin in the house the next day and even discontinue them the next day. I've done that multiple times. These are patients who will declare themselves. They're not sick in the overall compared to sepsis patients, so you have time to observe them and try to avoid inappropriate antibiotics in them. This is the part of the meta-analysis that looked at the LRTI group as well. And to note, there's 1,000 patients in the pneumonia group, for example, which is, those are good numbers. Looking at those patients who had PCT guidance for their LRTI or lower respiratory tract infection versus not, there was a statistically significant reduction in antibiotic initiation. And if you look at the patients who came to the emergency room and then were discharged from the emergency room back home, there was over a 50% reduction in antibiotic administration. I'm not an ER doctor. This is a very difficult job that ER providers do. One of the benefits here compared to those patients who are presenting similar to the doctor's office versus in the emergency room is that you can get a PCT level on them in the emergency room, and of course now you cannot get PCT levels necessarily in the office. And so you have this availability of extra data with your clinical know-how that I think is beneficial when you're in the emergency room. Of those patients who got admitted to the hospital where PCT was utilized for LRTI, a 38% reduction in antibiotic exposure was noted in those patients. If you look at specific diagnosis in this meta-analysis, you can see 37% reduction in antibiotic exposure for community-acquired pneumonia, a 65% reduction in those with acute bronchitis. I think that's probably the lowest hanging fruit in these three patient groups, and a 49% reduction in those patients with acute exacerbation of COPD. The days of using antibiotics in patients with COPD for its quote-unquote anti-inflammatory mechanism, I think, are over with C. diff and the problems that we have in our hospitals. So I think the next couple slides are fun, and it really highlights some of what we just covered. So let's go over some cases that I've taken care of the use of PCT, and we'll highlight a large majority of what we just talked about. Let's talk about the limitations. Limitations of any test are crucial, and PCT has limitations. We talked a little bit about that with the inflammatory piece. So you can have these kind of 2, 3, 4, 5 elevations. A PCT that stays flat, that's someone who's not infected. This is a 58-year-old patient with liver disease who came from a skilled nursing facility who has pneumonia in the emergency department with shock and fevers and respiratory failure on a mechanical ventilator, and sick. Everything about you says this person's got sepsis from pneumonia, and they're sick, and you can see on day one the procalcitonin level is 0.16. The next day, so what do? First of all, in the ER, you just use your clinical know-how and you treat those patients. You get the baseline PCT. We could potentially use this for its negative predictive value. It may have been super elevated, and you could use it for its positive predictive value in terms of escalation of antibiotic care, maybe. And you can see the next day, in this case, it went to 16. The key here is you've used your clinical know-how and you treated the patient. And this is a limitation. You're going to see some of these cases and you're going to use your clinical know-how and treat them appropriately. And this is just like any other test. I saw a case this week of a totally negative troponin with horrible unstable angina, multiple negative troponin levels, EKG not doing much, who ended up needing 2 staggered, stenting procedures. And so you're going to see this with PCT as well as other biomarkers. This is a 78-year-old patient with a sore throat and respiratory failure who's got thought to be sepsis on antibiotics, on mechanical ventilation. And over time, as you can see in the bottom, all the PCTs are very negative, at 0.1 and less than 0.1 and less than 0.1 over and over and over again. This person's got a lactic acid of 4, almost 4.5. That's all about perfusion. This is an actual digitalized copy of the plan for the patient, where we had CT'd the neck, and we followed PCTs. We initially provided antibiotics. This is just a monoviral infection for a patient with an opportunity where, in this case, DC, all antibiotics. You can see right in the line. Here's the key. This person was sick. You didn't just stop antibiotics in the emergency room. We needed that baseline PCT value so that over time, in this case, we could discontinue with more confidence in having a good clinical status and multiple negative procalcitonin values. And in this case, I want you to note that the viral panel was also positive. And I love the combination of a positive rapid viral panel and a negative procalcitonin. You have a lot of confidence there about what you're dealing with. The negative procalcitonin in this case is showing us that it's very unlikely that there's a bacterial superinfection. This is a 38-year-old male with diabetes who suffered a prolonged cardiac arrest and then fortunately improved their neurostatus. And in the emergency room has a procalcitonin of 34. On exam, this person looks like they got cellulitis. And you can get a PCT of 34 you can get with cellulitis. It's kind of high. They got antibiotics appropriately from the ER providers, and they were treated for their cellulitis. And then you can see we followed their clinical status. This patient just kind of wouldn't come off pressors, and the PCT came down with antibiotics, and then it starts going back up again. And in this case, that prompted me to get a CT scan of the leg, and we found necrotizing fasciitis. Patient required amputation and ended up surviving the hospitalization, although a long hospitalization. So I just wanted to draw the attention back to a couple things. Number one, PCT will stay flat or rise if you're missing the organism in terms of antibiotic selection. And number two, and in this case, PCT will stay flat or rise when you haven't got source control. If you haven't drained the hydronephrosis, it wasn't just simple urinary tract infection. PCT and the patient's clinical status are going to show you otherwise. That goes the same with perforations, abdominal. That goes the same with, in this case, a necrotizing infection that required amputation. So you're always going to go with your clinical know-how, but you're going to combine it. In this case, just kind of a flat presentation, just wouldn't come off, 10 to Levophed or so. And in this case, prompted us to get a CT scan. And I think the same goes for emergency room management. When you see very, very high maximal procalcitonin levels, that can be telling, and that potentially would change what you do with imaging and considering, again, as I stated, that your PCT rises and the sicker the patient is. This is a 78-year-old male with a history of heart failure and an EF of 15%, who's got a defibrillator and comes in with respiratory failure with that chest X-ray, admitted by our extenders with bilateral infiltration and edema. Patient's got no fever, no white count, and does not get antibiotics. And then within the next morning, and look at that chest X-ray. I don't know what that is. I mean, he's got a huge heart, and it's got a defibrillator, and looks like edema, and got a lot of associated things on chest X-ray that would push for that, but no fever, normal white count. Could be pneumonia, I guess. And then we had a delay in antibiotics here with a procalcitonin that comes back at almost 38, which then prompts antibiotic administration, and then later in the day, fever of 103. And so again, back to somewhat of what a surprise procalcitonin, or in this case, helps with a differential diagnosis between pulmonary edema and CHF. Maybe would have gotten antibiotics a little quicker if we maybe had the PCT in this circumstance a little bit earlier. So I'm going to roll through some of our references on the next couple of slides, but I really want to spend some good time in answering questions further from the audience. Happy to provide these references to anyone who would like to utilize them, and I really appreciate the audience here, and let's look forward to some good questions.
Thank you, Dr. Feinstein, for your presentation. A quick reminder for our audience on how to submit questions. Simply type them into the drop-down box located on the far left of your presentation window labeled Ask a Question and click on the Send button. Dr. Feinstein will answer as many questions as time permits. So the first question is, have you used Vitis Brahms procalcitonin, also known as PCT, results and a film array respiratory panel result together to make clinical decisions in patients with lower respiratory tract infection? And if so, can you tell me how and provide an example?
Yeah, great question. I think this is kind of on the forefront, really. We're living in a world now of rapid identification, which is super, right? Because 10 years ago, we just simply didn't have this stuff. And when you can have a positive viral panel, which again is telling you now part of the differential diagnosis, you kind of have a better idea of what started this, metapneumovirus positive, flu, and now a negative procalcitonin, which is then giving you information about is there a bacterial superinfection. That really brings a lot of confidence to discontinuation of antibiotics on day 1, day 2, or even day 3. I mean, but certainly discontinuing antibiotics and providing shorter durations.
Thank you. Next one is, on average, how many PCT samples do you envision being taken on a patient in the emergency department prior to being triaged to the ICU, or is it worth waiting until the patient arrives to the ICU?
Yeah, so I put this in the same category of a lactic acid level. You kind of want that as soon as possible. That's why we have point-of-care testing, and we're trying to skip some delays in the lab. You want to get the PCT, I think, pretty immediately. You want to then correlate it with the patient's clinical status in front of you. As a clinician who does the admissions and our friendly hospitalists, we got to have the baseline PCT to really in the ER to use that to look for 80% reduction going forward and for the negative predictive value. On the same token, I think you want to get the PCT immediately in the emergency room to correlate it with your patient's clinical status for the positive predictive value. So the answer is you want to get it right then and there, essentially, when you're getting your other lactic acid and other sepsis workup.
Thank you. Next one is, we are trying to program in an algorithm within our EHR to monitor procalcitonin levels as an indication to pharmacy for antibiotic de-escalation. What criteria would you recommend? We tried monitoring for a 25% drop, but this loses significance when the baseline procalcitonin is already very small.
Yeah, that's a great question. So get your iPhone calculator out, because you really should stick with the 80% reduction as the FDA has recommended up to 96 hours. When you have mature PCT programs, you do get potentially other opportunities as you get very comfortable with it, but I think you really should stick with the FDA claim with the 80% reduction. And if you have these low values, it's a great question. I think I'd still stick with 80% reduction even when you have these values less than 3 and 4. I don't think that the literature is going to suggest otherwise for sepsis patients right now. I just don't want any harm to come, from your patient groups.
Thank you. Insurance companies consider PCT as investigational. For example, they do not pay for the test done in the emergency room on outpatients. How do you justify the costs?
So I guess you're referring to ER patients who then kind of go home. So all I can do is make an extrapolation. So first of all, you could avoid antibiotics for a patient who then, again, didn't need them. And of course, I know we all think the same way, which is, of course, there's negative aspects to giving people antibiotics from their standpoint, from reactions and to C. diff and frequent exposure. So I know that you as a clinician want to avoid that. But in terms of cost, let's extrapolate from Bob Balk's study in chest in 2016. That's all I can basically do, because there's not a whole lot of data out there that looks closely at the financials for that specific patient who comes to the ER then goes home. But the bottom line in Bob Balk's, it was a retrospective review and premier data in sepsis patients, looking at those who got 1 or 2 PCTs, and in your case, you're getting 1. It was 33,000 patients who got PCT algorithm versus 98,000 of those who did not. And it showed a total reduction in money that was required of close to $3,000 in each patient who had PCT algorithm utilized versus not, and that was a p-value of 0.001. So I think, just in my mind, I don't have a lot of common sense at home, but in medicine I got common sense, and my sense is that this would extrapolate just fine with that patient from a financial burden to healthcare, of reducing financial burden using PCT.
Thank you. How long did it take you to implement these changes in your emergency department, and what is your compliance rate with PC testing with ED providers?
It takes some time. It probably takes up to 12 months or so. I think you have to be fair to your ER providers. They have to get used to seeing PCT levels and clinical presentations. So I've never measured the compliance in prior hospitals, but I did measure it initially in 2011 in a study in our critical care patients, and the compliance, quite frankly, really wasn't that good. It gets better over time with the maturity of a program and standardizing it on an order set with recommendations. That's my recommendation to you would be making sure that you have a standard algorithm protocol that really allows some information to be provided for, and education is just crucial, right? You have turnover in ER providers and nurses, physicians, and you just need to continue going down the path of education. But don't lose hope. I think this is like a 12-month process or 18-month process of improving compliance.
Thank you. Next one is, how do you recommend interpreting PCT in patients with chronic kidney disease, acute kidney injury, and end-stage renal disease?
Yep, super question. Love it. So let's tackle end-stage renal first, because in my mind, they're different than acute kidney injury patients to some extent. There's about 15 studies out there looking at the clearance of end-stage renal for PCT. It's probably about 10 to 15% of PCT is cleared through the kidneys. So those patients, you're going to see them. I have cases where they come in and their PCT is 4.5, it just stays flat. That's not someone who's bacterially infected. They may not have sepsis at all or LRTI. And so if that same patient comes in 2 weeks later and their PCT jumps to 15, which I've seen, and their baseline started at, and it drops then to 7 and drops to 3, well, that's someone who trended up and trended down, and they had an infection present. And so you can use it in a patient group. It's very similarly what I'm talking about, patients who are on the ventilator machine with ARDS. They may have this kind of PCT value of 2, 3, 4, 5, and it kind of goes up and it comes down. That's someone who's got VAP or concerns with bacterial infection. In terms of acute kidney infection, we need studies. We don't have them in terms of acute kidney failure. And from my anecdotal experience, I really think that the PCT tracks upwards slightly with acute renal failure creatinines and worsening GFR, and then comes back down, I think, when it recovers. But we just don't have data on that patient group. So I would treat the patient with acute kidney injury in general similar to one who doesn't have the acute kidney injury.
Thank you. We're getting so many great questions coming in. The next one is, how long is a reasonable amount of time in which to expect a PCT result from the lab?
Okay, great question. I really think 30 minutes is really where this test needs to be. You're going to act on it if it's got a positive predictive value. And there's been a few studies out there that have had delays up to 8 hours in their PCT results, and it affects patient management and patient decisions. I really there was one study that had an alert associated with the PCT by pass, and because there was a delay to the PCT, they got it really I think hindered patient care. So I think 30 minutes is something that a health system should be shooting for. You really should not be sending this out. This needs to be in-house.
Thank you. Can you discuss why pediatric patients are not included in the PCT-based exclusion criteria? Is this a lack of studies, or does PCT respond differently in pediatric patients?
Okay, cool. Great question. Neonates at 72 hours or less, you can have issues with false PCTs. But over 72 hours, I think that the pediatric population responds very similarly than to adults. This is why we don't have a tremendous amount of research in pediatric populations, right? Because it's the caution and the appropriate caution in the patient group. But there's a lot of success, a tremendous amount of success in using PCT in pediatric populations all over this country over 72 hours, and it's just the weariness and concern of that population in general. But this is something you're going to see a massive growth in the use of PCT in pediatrics over the next 5 years. And of all the populations, oh my God, this is the patient group that gets inappropriate antibiotics, and we need to concentrate on. So I just think it's just lagging behind, and it'll get there.
Thank you. Would you say your recommended sepsis panel would be PCT, C-reactive protein, and lactate testing?
So I'm not a big proponent of C-reactive protein. So it's so nonspecific. It doesn't do much for perfusion. But absolutely, PCT and a lactate is something that I'd be combining, yes.
Thank you. Is there a push with CMS guidelines and the sepsis guidelines to suggest the use of PCT instead of lactic acid?
No, CMS guidelines are right on target with making sure that we are using lactic acid for perfusion. You probably will see in time the recommendation of PCT being added to that. But again, these are just different markers with different purposes, and I hope with the study that we're embarking on here will give us some information about how to use them synergistically. But you should not be doing anything instead of.
Thank you. Sorry about that. How often should PCT be done in a 24-hour period from the ICU?
Yeah, great question. I think that the package insert would tell you can use it up to 12 hours or so. There's people who, in end-stage renal disease patients, will use it every 8 to 12 hours in general. That has not been my experience. I really think that you get it immediately in the emergency room. You get it the next morning on an algorithm, standardized protocol that automatically gets it in the next morning and gets it in the next morning, and you can make a decision about the next morning, which is up to 96 hours. But I think my past experience has been that we have had good success with getting it immediately, no matter what time it really is, 10 a.m. or even 10 p.m., and then getting it the next morning on a standardized protocol, and then the next morning after that.
Thank you. For a hospital that has not yet adopted PCT testing, where would be a good place to start to get the best outcomes to validate utilization?
Yeah, good question. So first of all, this push should really be coming from the clinicians. The clinicians at ID and critical care and hospitals, ER, they're the ones who should be raising their hand to say we think we need this. I have my personal bias is just from my experience level that you need to start out with a negative predictive value. You need to use it for antibiotic stewardship first and foremost, and not necessarily for its positive predictive value of seeing if it kind of surprises you. That you should be looking at the negative predictive value for antibiotic stewardship from the beginning, and you're going to see reasonable results in reducing days of therapy per 1,000 patient days, which will kind of keep you solid with not having census impact that.
Thank you. As a laboratory technologist, how can we help assign the emergency room when it comes to PCT? As a laboratory technologist, how can we help assist the ER when it comes to PCT?
Well, I think it comes with the turnaround time and having the proper independent machine, the Vitus Brahms PCT to to be used, and making sure that you get it and understand that it is a priority for the clinicians on the other side to get that information within 20 to 30 minutes. You can't batch this. You can't and should not batch this this test. So I think that would be your responsibility to come up with something amongst your team in the lab that does it and gets it provided within a timely manner.
When would you recommend a repeat PCT in the emergency department when the first PCT is negative, however, clinical presentation has high suspicion of infection and the hospitalists are not sure about admission with first negative PCT?
I've never been asked that question. I think it's a superb, awesome question. I think the answer is, first of all, you're going to go with your clinical know-how. So if they don't look good and you're concerned, then admit them and get it next morning. On the other hand, if they look, you're not quite sure, you admit them or not admit them, I don't think there's a good answer out there. But I have some colleagues in other states and things that do it in 8 hours. So maybe you put them in an observation period and you get it in 8 hours. Certainly the package insert would say that you could do it in 12 hours. But this thing rises pretty rapidly. So I think you could make an argument to getting it earlier within 4 hours, 4 to 6, again 4 to 8 hours in an observation type of area. I doubt you want to keep them in your emergency room that long.
Thank you. The next one has several parts, so just let me know if you need me to repeat. I'll read it all first. Do you have any comments on some of the more recent literature on looking at PCT values, specifically in lower respiratory tract infections in the emergency department? For example, the recent study by David Wong et al. Published in the New England Journal of Medicine in 2018 reported that when looking at lower respiratory tract infections in the emergency department, they found no difference in total antibiotic days. Patients that received any antibiotics or antibiotic days during hospital stay between patients that were ordered a PCT versus those that were not. It seems more recent literature than what was cited in the presentation has found PCT less useful in regards to lower respiratory tract infections in the emergency department, specifically when looking at antibiotic use.
Yeah, I'm glad you're bringing this up. It's a great thing you're bringing up, and certainly I read that article. And here's the key of the disappointment of that study. And I can speak from my own experience. When you have procalcitonin, mature programs is when you get compliance and you get good results from the use of discontinuation of antibiotics and the negative predictive value. And unfortunately, with the New England Journal study, the biggest disappointment is overwhelmingly everyone involved in that trial never used PCT before. So they didn't probably have the confidence and the experience level that other providers who've had experience, like in the meta-analysis, Cochrane analysis, of using PCT had. And I don't think it's a small thing. I think that's a big thing. So I agree with you that we need more trials in LRTI. But I think that study was discounted substantially for me because none of the providers had experience with PCT prior.
Thank you. So it looks like we have time for one more question. Could a right lower quadrant pain patient with low PCT and normal CBC be considered very low risk of acute appendicitis?
I'll go with a no on that one. I would just come back to the most important premise, which is use your clinical know-how. If you got a lot of right upper quadrant tenderness and PCT is negative, that person could go down pretty quickly. You miss the diagnosis of acute cholecystitis. You don't resuscitate. You don't give fluids. You don't investigate further. I know you mentioned the right upper quadrant ultrasound. You might want to still kind of correlate that with the CT, even if PCT is negative, getting more data. All studies have sensitivity and specificity. All studies have false negatives, including PCT and right upper quadrant ultrasounds and CTs. So my sense on that question is just go with your clinical know-how still, let the dust settle, provide care that's based on what your presentation looks like, and then maybe correlate with a CAT scan with the right upper quadrant, repeat the PCT the next morning.
Thank you. I would like to once again thank Dr. Feinstein for his presentation. Do you have any final comments?
No, appreciate the questions were superb, and I think that we've got ourselves something here that's that certainly has lasted the test of time in terms of a sepsis bacterial infection marker, and the data just continues to overall go in the right direction. And again, I would try to standardize the use of PCT in your health systems. That's going to be a significant in terms of success for everybody.
Thank you. I would also like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today will be addressed by the speaker via the contact information you provided at the time of registration. We would like to thank our sponsor, BU Meria, for underwriting today's educational webcast. Until next time, goodbye.